Welcome everyone to topic 6, and this topic is on blood pathophysiology and pharmacology. We will have 3 parts to this topic, and this first part is on anemia and polycythemia. So what we'll be discussing in this part of the topic are the causes and the clinical manifestations of both anemia and polycythemia. We'll look a little bit about, the blood tests that are used to diagnose anemia. We're going to talk about how chronic cardiovascular disease and respiratory disease can result in a condition called polycythemia. And then we're going to sort of advance this to look at the risks of polycythemia and hypercoagulation, which will then lead into the second part of this topic, which is on hemostasis disorders. So this is just sort of a great big overview of the things we're going to discuss in blood pathophysiology, and pretty much, dividing it into 4 sections. We're going to start over here looking at anemia, which is a decreased oxygen carrying capacity of the blood. It might be due to low red blood cell numbers, but there are lots of other causes of anemia. So remember just here that anemia, is a condition that can be caused by, low red blood cell count or low hemoglobin, but it may also be a symptom of an underlying condition such as, a nutritional disorder or even a parasitic infection or bone marrow disorder. Once we get through anemia, then we're going to move over here and we're going to talk about polycythemia. And polycythemia describes an increase in red blood cell concentration. That might be due to an increase in, the number of red blood cells. That might be, a bone marrow condition, or it might be due to cardiovascular or respiratory disease that will stimulate EPO production from the kidneys to increase red blood cell production. Or it might be due to something like dehydration, where there's a decrease in the volume of plasma and therefore an increase in the red blood cell concentration relative to that volume of blood. But we'll get on to that later. And when we're talking about polycythemia, this then feeds in really well to this hypercoagulation part of this topic. Hypercoagulation is where, the blood clots too easily, as it says there, and therefore that increases the risk of thrombi forming on blood vessel walls, and then that also increases the risk of embolism. So if part of that blood clot breaks off to form a plug or an embolus, that then goes, and plugs smaller blood vessels to cause, states of anoxia. And then we're going to finally finish it up with these bleeding disorders here. And obviously with a bleeding disorder, we have a situation where the blood is not clotting sufficiently, and that's going to lead to things such as hemorrhaging, such as what we see, with a hemorrhagic stroke. To begin with, though, we're just going to do a little bit of revision on the hematocrit. Okay, so if you were to take a tube of blood and spin it down in a centrifuge, what you would find then when you take the tube out of the centrifuge is that we would have the blood settling into sort of 3 different compartments. The upper part there is the plasma, and remember that, the predominant sort of component of plasma is water. Then we have this smaller buffy coat here, and the buffy coat contains white blood cells and also the platelets. And then settling down the bottom of the tube are the red blood cells. And this is, called the hematocrit or the packed cell volume. So what is the hematocrit? It's the percentage of a blood volume that is red blood cells. Okay, and remember, that the number of red blood cells and the amount of hemoglobin will determine the amount of oxygen that the blood can sort of carry around the body. So really importantly, when we're talking about the hematocrit, it's the percentage of 100 ml volume of blood that is red blood cells. It is variable between males and females, and even within males, it can vary between 42 to 52%, an average sort of being 47%, let's say, and females slightly less, varying there from 37 to 48, so kind of taking an average there of 42%. When we look at the hemoglobin concentration of whole blood as well, there are differences between males and females. You can see the values there. And the values are lower in females due to the hormone, the steroid hormone testosterone, which stimulates red blood cell production. There is less in females, and therefore, the less hemoglobin count there. And obviously females have periodic menstrual losses too. Now, if this hematocrit increases, so gets abnormally high or abnormally low, this is going to cause problems. For example, if you have sort of a higher hematocrit, that's going to cause the blood to become thick. So it's going to become viscous. It's going to be flowing more slowly through vessels, and it's going to be more prone to clotting. As well as that, the heart is going to have to work much harder to push that blood through the circulature. Now, we'll get on to these abnormally high hematocrits when we're talking about polycythemia, but first of all, we're going to start with anemia. So, anemia is a decreased oxygen carrying capacity of the blood, and it may be due to a decrease in the number of functional red blood cells, but also a decrease in the amount of functional hemoglobin. There are many different causes of anemia, and remember that's because, anemia is often a symptom of an underlying condition. The most obvious, though, cause of anemia would be blood loss or hemorrhaging. Okay, if you lose blood, you're going to lose, that ability to deliver oxygen to tissues. Hemolysis is another example of a cause of anemia, and this is a good example of a cause because if you think about what hemolysis is, it's lysing or bursting of red blood cells. Now, there is a parasite known as a plasmodium, and it completes one of its stages of its life cycle inside red blood cells, causing them to lyse. So in this case, the actual cause of the anemia is the parasitic infection. So to treat the anemia, you would treat the plasmodium infection to begin with. Now, there are lots of other causes which we're going to talk about, including bone marrow failure, also some nutrient deficiencies, such as the deficiency in iron or vitamin B12 or folic acid. And anemia can also be caused by abnormal red blood cells and also abnormal hemoglobin. In terms then of clinical manifestations of anemia, the overall sort of symptom being fatigue. And when somebody has anemia, there are these compensatory mechanisms that kick in. So the heart will beat faster. So there's an increase in heart rate to cause tachycardia. There's an increase in plasma volume and ventilation. And in some cases, there's an increase in the number of immature red blood cells, which does tend to exacerbate the problem. So if we look at these sort of three tubes here showing you different hematocrits, here we've got the normal hematocrit. And what we're interested in here is what happens with anemia. So you can clearly see that the hematocrit percentage is much depressed or much lower compared to that normal blood. Remember again what the definition of anemia is. It's a diminished oxygen carrying capacity of the blood due to insufficient functional red blood cells or insufficient functional hemoglobin. Now, as I mentioned on the previous slide, in terms of the sort of clinical manifestations and symptoms, one of the common symptoms includes skin pallor. And pallor just means sort of blue, pale skin. And there is, a tendency to have sort of a bluish tinge to the skin. And that's because, deoxygenated blood has that bluish color, whereas oxygenated blood tends to be reddish color. So in somebody with a sort of normal hematocrit, the skin will have sort of a reddish tinge, and that's due to that oxygenated blood flowing close to the surface. But in somebody with anemia, they tend to have, much paler skin. Compensatory mechanisms kick in trying to, increase the delivery of oxygen to tissues. And this includes tachycardia. And tachycardia is abnormally high heart rate. And also palpitations. And palpitations is that conscious feeling of your heart beating in your chest because your heart is working so hard. So the body tries to increase cardiac output to compensate. Remember, cardiac output is the amount of blood pumped from the heart per minute, and we calculate it using the stroke volume and the heart rate. So here the heart rate is increasing to try to increase that cardiac output. And that's what's causing the tachycardia, right? There is also this sort of overlying sort of symptom of fatigue. Now, there are other sort of signs and symptoms when the anemia is caused by, other things. When the anemia is caused by the abnormal lysis of red blood cells, this can result in hyperbilirubinemia. So bilirubin accumulating in the blood, so abnormally high levels of it, which leads to jaundice. And jaundice being that sort of yellowish color of the skin and also the eyes. And you can also get gallstones. So, here we're talking about stones in the gallbladder, are also, common symptoms when you have this abnormal lysis of red blood cells that's causing the anemia. And these gallstones are forming due to the accumulation of waste products. And then, those waste products sort of precipitating out of solution to form stones. But here we're talking about in the gallbladder. So now looking in a little bit more detail at the causes of anemia, and the most obvious one here is blood loss. So hemorrhaging, losing blood will cause anemia. Secondly, hemolysis, and we see this with malaria. Remember, malaria is caused by a plasmodium, and a plasmodium is parasitic infection that it gets inside red blood cells, completes its life cycle, causing those red blood cells to lyse, and this is what's causing the anemia in this case. The third one then is this deficient red blood cell production. So this might be a result of bone marrow failure. Now, firstly, this can be genetic. And so some people who have this genetic disorder called aplastic anemia will have a decreased number of red blood cells, white blood cells, and also platelets. But it's the decrease in the red blood cells that's causing this anemia. I'm not sure if many of you remember, it was quite a few years ago now, there was a footballer called Nick Riewoldt. I'm sure you all know him if you've got an interest in watching AFL, and he's a commentator. But his sister had aplastic anemia, and she died from that several years ago. Bone marrow failure, though, can also be induced, and that can be due to chemotherapy treatment for cancer. And again, that will cause decreased red blood cell production and therefore the anemia in this case. We also have nutrient deficiencies which can cause anemia. So insufficient iron in the diet can cause iron deficiency anemia, also vitamin B12 and also folic acid. Now, in terms of the vitamin B12 and the folic acid, these are required for DNA synthesis and therefore red blood cell production. So deficiencies in these is what's leading to the anemia. Vitamin B12, for some people who are vegans, they can sort of have this, vitamin B12 deficiency anemia. But remember that our bodies are really good at storing vitamin B12. And it's usually only sort of several years after somebody, has become a vegan that they might find themselves with anemia due to a deficiency in vitamin B12. And again, this would only be if they weren't getting their vitamin B12 from other sources. The most common cause, though, of a vitamin B12 deficiency is an autoimmune condition called pernicious anemia. Okay, I need you to think back to last year. We talked about a factor called intrinsic factor that's produced by parietal cells in the stomach, and it binds to vitamin B12, and that helps in its absorption from the small intestine. But with pernicious anemia, the immune system is producing an autoantibody that's destroying these parietal cells, right, in the stomach. Therefore, you get decreased intrinsic factor production. Less intrinsic factor production means less binding of the vitamin B12 to the intrinsic factor, and therefore decreased absorption of that vitamin B12 from the intestine, therefore less vitamin B12 for red blood cell synthesis, which is what's causing the anemia. As I mentioned as well, you need folic acid for red blood cell synthesis too. The next one then is abnormal red blood cells. So you might have the normal number of red blood cells, but these red blood cells have membrane problems. So the cells are the wrong shape and they're non-deformable. Remember that red blood cells need to be kind of bendy or flexible so that they can fit through those really small capillaries with those tiny diameters. So if you have red blood cells that are not flexible, then you're not going to get adequate oxygen delivery to tissues through those small capillaries. In addition to this, these sort of stiff or non-deformable red blood cells get trapped in the spleen and they get removed more quickly than they should be. The next one then is deficient hemoglobin production. We can see this with an iron deficiency, which is caused by chronic blood loss or, menstrual disorders in females. And the final one here is abnormal hemoglobin. And we see this with sickle cell anemia. Now, sickle cell anemia is a genetically inherited disorder where there is, a mutation in one of the genes that codes for one of the proteins in the hemoglobin complex. Because there's an abnormal gene, that's going to result in an abnormal shape of the hemoglobin and therefore an abnormal shape of the red blood cells. Okay, so what happens here is that they tend to have this sickled shape, and because they have this sickled shape, they tend to get clogged or trapped in smaller blood vessels, and that causes, tissue hypoxia downstream of that blockage in the vessels. And it also causes pain as well due to the, getting trapped. So I guess here we're seeing the anemia because of the abnormal shape, and the abnormal shape of the hemoglobin means that it can't bind to oxygen properly, and that's what's then causing the tissue hypoxia and the anemia. Now we look very quickly at some blood tests for anemia. Obviously the hematocrit, so an abnormally low hematocrit might indicate anemia. Also blood smears. So here, if you worked in a pathology lab, so if you were a laboratory scientist, you might be taking a drop of blood and putting it on a glass slide and looking at it under the microscope to look at, the size, the color and the shape of red blood cells. Now, we don't expect you to know any detail about this, but with some types of anemia, they're very small red blood cells. So that would be microcytic anemia. In some other types, they're really large red blood cells, and that's called macrocytic anemia. Also, the shape, the most obvious one there would be somebody looking for sickle cell anemia. The presence of abnormal red blood cells might also be looked at. So remember, those red blood cells have that biconcave disc shape that, increases that surface area for oxygen transport, but also, allows them to be flexible. And I talked about that on the previous slide. And they might also be looking for the presence of immature red blood cells, which I'll talk about in a minute. Other sort of tests then are the hemoglobin count, so abnormally low hemoglobin count indicating anemia, and also looking at different iron tests as well. Now, I know I'm talking about anemia here, but some people can have abnormally high hemoglobin levels, and the most common cause of that is a genetically inherited disorder called hemochromatosis. And in people with hemochromatosis, there's increased absorption of iron across the gastrointestinal tract wall. Now, normally the absorption of iron is tightly regulated. Obviously, I think everybody knows that iron is essential for, hemoglobin, and also then for the binding of oxygen to the iron molecule within hemoglobin to allow proper transport of that oxygen. Here, though, people have too much iron being absorbed, and that iron is toxic, right? And it, could damage the kidneys and the liver and also the pancreas. So with people with hemochromatosis, to keep those iron levels sort of low, they would regularly donate blood. So looking again at this compensation for anemia. Now, there are particular mechanisms that do kick in to try to compensate for the decreased efficiency of oxygen delivery to tissue cells. In slow onset anemia, so if it's slow in its onset, then there can be gradual increase in plasma volume, cardiac output, and breathing rate, which often compensates for mild to moderate anemia. However, if the person already has either respiratory disease or cardiac disease, then this sort of compromised respiratory and cardiac function limits the compensation, okay? Then in addition, in hemolytic anemia, the bone marrow production of red blood cells may increase. Kind of makes sense to try and replace lost red blood cells. But this can actually make the condition worse because this can increase the number of immature red blood cells present in the blood, and immature red blood cells, can't carry, oxygen as well as mature red blood cells. Now, I have put a little problem here for you that we will go through in the tutorials with you. And it is this one. Approximately 25% of people over the age of 80 have anemia. So it is very common in elderly people. So what may contribute to this increased risk of anemia, and what may be the consequence of this anemia? So try to think about this, in your own study time. But just to sort of give you a little few tips, kind of, as we age, our red bone marrow is converted to yellow bone marrow, and therefore, there's a decreased ability to produce red blood cells because of this, and also remember a decreased ability to produce white blood cells and also platelets. So that's going to obviously affect or increase our risk of infection, decrease our healing time, and also have effects on clotting too. Remember that elderly people also sometimes have very poor diet. So they might have diets that are deficient in iron, vitamin B12 and folic acid, and that will also be a cause of anemia. Remember, elderly people too might have cardiovascular damage or respiratory damage, and that will then, of course, decrease that oxygen delivery to tissue cells. Now, where this might become a bit of a problem is if they also have kidney damage. So the cardiovascular and respiratory damage will stimulate the kidneys to produce EPO. And EPO is that hormone then that increases red blood cell synthesis. But if they already have kidney damage and they have cardiovascular damage, then it's pointless, right? So the kidneys won't be able to produce that EPO, and that's what leads to the anemia. Okay, so I'm going to stop here. That's all I'm going to say about anemia. And when I come back, I'm going to be talking about polycythemia.